Hi, my name is Mia Foltz, and this is my presentation for EXS486 on cystic fibrosis. So some pathophysiology behind cystic fibrosis. It's basically the buildup of a thick mucus in all of the body's major organs as a result of a mutation in the cystic fibrosis transmembrane conductance regulator, also known as the CTFR gene. The increase in mucus production results in damage to the digestive and respiratory systems especially. This results in lung disease, malnutrition, and chronic endobronchial infections. In an individual who does not have CF, mucus acts as a protective and lubricating substance. It lines all of the organs and tissues in the body. CF causes the body to produce mucus that is too thick and sticky, resulting in suboptimal functioning of the organs. Bacterial infections in the lungs are common, as well as wheezing, coughing, and inflammation. Mucus production can damage the pancreas, affecting its ability to produce insulin and digestive enzymes. Problems with digestion can lead to diarrhea, malnutrition, poor growth, and weight loss. A shortage of insulin can cause a form of diabetes known as cystic fibrosis-related diabetes mellitus, CFRDM. Some epidemiology and risk stratification for CF. So in the US, approximately 1,000 individuals are diagnosed with CF each year, with the vast majority of these people being of Northern European ancestry. In fact, in 2014, they found that 93.9% of individuals in the patient registry were Caucasian. Back in 1966, CF was a disease primarily affecting children. In the patient registry, only 6% of the population was over the age of 18, and only 0.1% was over the age of 30. However, over the last 30 years, there's been a steady increase in the adult population of people with CF. And for the first time in 2014, the adult population made up over half of the individuals in the CF patient registry. A person is at a higher risk for having cystic fibrosis if one or both parents is a carrier of a mutated CFTR gene or has cystic fibrosis due to the disorder being autosomal recessive. A person is also at a higher risk if a sibling, half-sibling, or a first cousin has cystic fibrosis. A little bit of research on CF and exercise. So this first study is the prognostic value of exercise testing in patients with cystic fibrosis. Basically followed a group of patients, 109, over 8 years to determine factors associated with subsequent mortality. After adjustment for other risk factors, patients with higher levels of aerobic fitness were more than 3 times as likely to survive than patients with lower levels of fitness. Although better aerobic fitness could simply be a marker for less severe illness, measurement of VO2 peak appeared to be valuable for predicting prognosis. In addition to improved aerobic fitness, patients also had increased cardiovascular efficiency and ventilatory muscle endurance after aerobic exercise training. This is basically important because respiratory failure is a big cause of mortality among patients with CF. And if we can improve their ventilatory muscle endurance through aerobic workouts, we can decrease the risk of respiratory failure and improve their prognosis. A little bit more research on CF and exercise. So this is a study among pediatric patients. So there was a group of children doing aerobic workouts, a group of children doing resistance training, and a control group. It basically found that the group doing aerobic workouts had lower risk of respiratory failure with a higher VO2 peak. The children doing resistance training had better weight gain, which is great because malnutrition and failure to thrive is really high among children with CF. And overall, it concluded that a combination of aerobic and resistance training may be the best training program for children with CF. The last study I found on research of CF and exercise is actually called Exercise Medicine in Cystic Fibrosis. So this study was kind of a review of all the literature that goes along with exercise in CF, and it had a lot of really exciting conclusions, like CF patients with a VO2 peak greater than 82% of their predicted value had an 83% 8-year survival rate, compared with only 28% 8-year survival rate for patients with a lower VO2 peak. This is exciting because we can improve the prognosis of these patients by improving their VO2 capacity. This study found that aerobic fitness was an independent predictor of 8-year survival, whereas forced expiratory volume, the original gold standard for disease progression and life expectancy, was not. Exercise tolerance, aerobic capacity, and respiratory muscle endurance all were greatly increased in a study of subjects completing a 3-month supervised running program. Unlike subjects in the control group, subjects who completed the running program demonstrated no significant decline in pulmonary function. Exercise also tended to increase mean daily sputum expectoration weight. This is important to improve lung function. Sputum expectoration is really important in patients with CF, and they go through a lot of treatments every day and chest physiotherapy to increase this expectoration, which helps their lung functioning. This study demonstrated a better quality of life and suggests increased life expectancy for CF patients who exercise. So for my case study, Sam, a 20-year-old with cystic fibrosis, comes to you looking for an exercise program. She's looking to gain muscle mass as well as improve her aerobic capacity. Sam experiences persistent fatigue and has a chronic cough. She experiences shortness of breath, especially when exercising. She enjoys walking, yoga, and cycling, and she likes working out with others. Sam often feels isolated due to the frequency and duration of her hospitalizations and treatments. Her doctor would like her to increase her strength to improve her functional ability to perform activities of daily living. Sam is 5'4" and 104 pounds with a BMI of 17.8, putting her in the underweight category. Her resting BP is 92/64. She has a resting heart rate of 78 beats per minute. Her total cholesterol is 145, HDL 70, and LDL 72, which is all in the normal range. She has a PICC line in her right arm. She regularly takes antibiotics, mucus thinners, and bronchodilators. So exercise testing with patients who have CF should be done under the supervision of a physician getting all the required medical clearances. Also, constantly monitoring for signs and symptoms. You can utilize the Borg RPE scale, and another great one is the modified Borg dyspnea scale to monitor shortness of breath. Signs of poor perfusion like cold and clammy hands and having a pale face, shortness of breath, and wheezing are all indications to terminate an exercise test immediately. So some testing options for her: the body composition, skin fold measurements to gauge improvements in fat-free mass should be done. We're looking to increase lean body mass here as well as overall body weight because of her risk for malnutrition due to her condition. Cardiovascular fitness. The modified Bruce treadmill protocol is beneficial to estimate VO2 max, and she's going to have a lower VO2 max due to having CF and a greater percentage of dead space in her lungs. So the modified Bruce treadmill protocol will be effective in estimating her VO2 max, and if we can improve that, we can possibly improve her prognosis and quality of life. Muscular fitness, so chair stand test to demonstrate functional muscular endurance in the legs. This is helpful in estimating muscular endurance as well as her ability to perform activities of daily living. Flexibility, the sit and reach test to show trunk flexibility is usually accessible to most patients, and this will be a good jumping off point to estimate her ability to maintain flexibility and decrease her risk of lower back pain. For balance, the unipedal stance test is helpful to estimate fall risk. In patients who are immunodeficient or at high risk of infection, we definitely don't want her to be in the hospital for any reason like falls, so preventing her from falling is going to be helpful in preventing any unnecessary hospital stays. So her exercise prescription, the goals are to increase cardiovascular fitness, facilitate mucus clearance, and improve ability to perform activities of daily living to increase overall quality of life. She should choose activities that are enjoyable, like walking and cycling, and work up to a moderate intensity. She should start slowly with like 10-minute sessions and then build up to 30-minute sessions. 2 days per week, she should do 10 repetition sets of light resistance strength training, targeting the major muscle groups, using the RPE and dyspnea scales as well as heart rate to measure intensity and adjust workouts according to fluctuations in symptoms. So a table that shows exactly what she should be doing each week. For aerobic training, she wants to start off with probably 10-minute sessions, 3 to 5 days per week, work up to 30 to 34 to 45 minutes, doing 40 to 60% of her heart rate reserve, which would be about 80 to 120 beats per minute. Or on the RPE scale, she wants to be about 12 to 13. She could do treadmill, cycling, or walking and riding a bike outside with a friend, depending on the weather. Resistance training should be 2 to 3 times per week, 10 to 15 reps per set of 40 to 60% of her 1 rep max. This should be for about 20 to 30 minutes, starting off at 20, doing squats, lunges, or lower body focused yoga pose like a warrior flow. And then for flexibility, she should be doing about 2 to 3 days per week of stretching to a point of slight tension, holding for 10 to 30 seconds. Static, dynamic, ballistic, and PNF stretching are all appropriate. A couple modifications and precautions for exercising with cystic fibrosis. So first of all, immune deficiency. Wiping down equipment before and after use, working outside if the weather permits, and maintaining a 6-foot distance if we're in the gym, so just normal coronavirus precautions at all times. Shortness of breath, so we want to monitor the SOB using the Borg dyspnea scale, maintain an intensity that's comfortable, and if there's any wheezing or shortness of breath, the exercise should be terminated. She'll have a lower VO2 max, so ventilation will be a lot higher for each workload compared to her peers, so workload's going to be decreased significantly to achieve that VO2 max. She has a PICC line in her right arm, so there should be no swimming. She can't submerge it, no contact sports, and no strenuous upper body workouts like a HIIT workout, so no flailing around. If you damage the PICC line, there's a risk of infection or injury, so focus on building the lower body strength and the aerobic capacity for functional activities of daily living and that increased risk to decrease the risk of respiratory failure. She will also have altered sweat gland function, which has to do with the regulation of her ion channels being malfunctioning due to the CTFR gene mutation. So she will be prone to dehydration and electrolyte imbalance, especially during exercise in the heat. She can work out inside when it's too hot or humid and monitor signs and symptoms constantly. Hydration should be encouraged. So here are some of the sources that I found for the research on how exercise is medicine for people with CF. And yeah, I hope you learned a lot, and thank you.